So I'm Laura's Heit, and today I'll be talking about the process I went through to build a strength-based standardized reporting tool for Island Health to use with its pregnancy outreach programs. A huge gratitude to the Lekwungen people, the Songhees and Esquimalt First Nations, on whose lands and waters I have been privileged to live and work and learn the last year and a half, and to those Saanich peoples on whose land we're meeting today. Also, an enormous thank you to my fantastic practicum supervisor, Jenny Nyhoff, and to the whole team of population and public health at Island Health. They were just fantastic to be a part of their team for my practicum. So Island Health is one of British Columbia's 5 regional health authorities, serving 860,000 people across Vancouver Island and the Johnston Strait, and provides acute, primary, and preventative healthcare services to these folks and over 50 First Nations. Their population and public health portfolios includes teams like immunization, surveillance and epidemiology, communicable disease prevention, and public health, where I was privileged to work with the perinatal program manager in perinatal programming. So Public Health Perinatal Services offers universal services for all pregnant people and new parents, and enhanced services for the folks who are experiencing barriers to care due to societal and systemic inequities and challenging life circumstances. One of these enhanced programming offerings is contracting community organizations to deliver pregnancy outreach programs in 6 communities across Vancouver Island. So these programs are non-clinical community organizations that offer services to pregnant people and new parents. So these can include peer support and education group, one-to-one support from non-clinical program staff, referrals to other services like healthcare, food support, mental health and substance use care, and outreach meetings in folks' homes or in the community. So why contract community-based programs to deliver these services? Because they're going to increase accessible and culturally appropriate services for pregnant people who might not be accessing traditional prenatal health care. So some of the research on barriers to prenatal healthcare usage indicate that folks might have a lack of trust in healthcare professionals. They might have had previous negative healthcare experiences or experienced culturally inappropriate care, inflexibility in the healthcare system, or live in areas with inequitable service provision. So some of the ways that pregnancy outreach programs address these barriers is by having flexible programming that can respond to their communities and their contexts. It's in non-clinical settings, which can be less intimidating for people. And they have peer support coming from non-clinical staff in the groups that they offer. They can also offer culturally appropriate care. The Indigenous organizations that Island Health contracts to offer the care, they know what's best for their Indigenous clients. So my project was to develop a reporting tool for these programs to use to report back to Island Health. Why did we need a new tool? Because Island Health is now centralizing program management. There's a new position of perinatal program manager. And having standardized data collection can support multi-program management. So impact evaluation, resource allocation, data-driven decision-making, and long-term planning. The priorities I had when creating this tool were that it be a strength-based, culturally sensitive, and celebrate program successes. I wanted it to simplify reporting, so programs didn't have to develop new data collection tools. And this could respect the program's capacity. Some of them are very small organizations. And it can help support positive and collaborative relationships between the programs and between Island Health. It needed to allow for quick and easy data analysis, and to collect on the key performance indicators so we could understand programs' reach and activities, their outcomes, their impacts. So the methodology I had when developing this tool was to start with an analysis of their contracts and the current reports that they were providing to Island Health. I carried out an environmental scan of available or similar tools, looked into best practices for pregnancy outreach programs. I researched how we could center Indigenous knowledges as we were creating this tool, choose optimal data collection for analysis, and incorporate collaborative best practices in the tool and how we would share it with the programs. And all along the way, I was sharing the tool with the management and leadership teams so that we could have feedback and we could collaborate on how everything was going. So just jumping into a couple of things quickly. The contract analysis, of course, was key because we needed to find out what the contract requirements were and identify what questions can help us learn if the programs and how the programs are reaching the target populations, working towards their objectives, and carrying out the required activities. So current report analysis showed us what the programs are currently reporting, and from that I could extrapolate to understand how they were collecting their data, because it was important that they didn't have to do more data collection tools, respect organizations' capacity. When thinking about culturally sensitive collaboration, I found this really wonderful anti-racist evaluation guide from an organization called West Ed, and I made myself a checklist to use during the process of creating the tool. So some of the things from the checklist were, am I recognizing the community as the experts in their own work? Am I ensuring that data collection methods reflect alternate ways of building meaning, like narrative or storytelling? And have I considered all parts of the tool through trauma-informed and strength-based lenses? So some of the ways that this evaluation, anti-racist evaluation, made it into practice was this section. These are just small excerpts, of course. Learning about communities and context. So it begins with the recognition that the program is unique. They're the experts in the work and the communities that they serve, and that we want to celebrate their work and we're grateful to learn from them. So I asked what makes them proud of their program and what healing practices they've found to work for their community. So this section I found very interesting to work on developing. It's the client demographics and social determinants of health section. So it starts with the recognition of systemic and societal injustices that lead to the unequitable health outcomes for certain populations. And that includes a recognition of colonization. So the questions will help understand the program's positive impact. So I ask for what proportion of your clients are part of these 4 groups, and ask for what successes or impactful moments that they would like to share. And then moving into social determinants, I ask what proportion of clients have concerns about money to pay for their basic needs, and what proportion of clients are experiencing challenges related to substance use. So why is it like this? What were some of the challenges and solutions I found when developing? So first you need cross-comparable data. You can't do multi-program management if you're having values come in absolute values. So this is why we asked for proportions here. What proportions of your clients? No new data collection tools to respect all the programs. So this is why we asked for percentile ranges here. So we have none, all, 1 to 25%. Because if the programs aren't already collecting this data, we don't want them to have to create something new for this. So it sacrifices precision, but we'll still have an accurate idea of the program's demographics. How do we avoid stigmatization? Well, we're identifying clients that are quote unquote more vulnerable. So in a lot of tools, we have identity factors and social determinants of health mixed together. So this separation I had was deliberate, of having identity factors apart from different social determinants of health. And also the recognition of the systemic and societal causes of inequities and the successes and impactful moments. How did I identify what data points I was going to include in this? So in this section in particular, I referenced a lot of perinatal nursing, I don't know, I'm forgetting the words for this one, but it's totally cool. Nursing priority screening tools. There we go. I I got a thumbs up from my supervisor there. So we did an environmental scan, actually, of different health authorities to find out how the different authorities are identifying target populations. So in this one, I used a Vancouver resource particularly because they did a lot of research behind it. How do I incorporate a strength-based perspective into the entire tool? One of these things was doing person-centered language. So what proportions of clients are experiencing challenges related to substance use or alcohol, non-prescription drugs? So people-first language the whole way through. I am running out of time, so I'm going to do this very quickly. I'm not going to be around for the data analysis section. I hope that the quantitative data analysis is going to be able to be described with visuals in different ways. So looking at things over time. What are clients served over time? What programs are getting bigger, getting smaller, maintaining? And red flag questions, like organizations where you're having low levels of breast or chest feeding. Is there something that Island Health can do to support them? So in conclusion, I hope that this resource can be helpful for public health as a new resource for strength-based, evidence-formed, and relationship-first program management and evaluation. Thank you so much for listening. And I would love your questions.